Okay, perhaps the panel will take their seats. So this has become a now fun annual event. We've sort of tried to be pretty academic during all the presentations up until now, having to do with health policy and the healthcare system. And this is sort of our opportunity to air some of our differences, let our hair down, be a little bit opinionated. Yeah, right. And you might object to our panel in some respects. I mean, you might say, well, there's a bit of an over-predominance of testosterone on this panel. And that would be a fair thing to say. But I think in regard to its suitability for this discussion, it's super appropriate in that what we do have on this panel in a high proportion is viewpoint diversity, which I think is what we need for a productive engagement with the healthcare policy issues that are so pressing at the present moment, so that perhaps by productive conflict, and I don't have the John Stuart Mill quote that I used last year, but the thought is that the conflict of ideas can often result in a closer approximation to truth than if that conflict is avoided. Now, you've met everybody on the panel with the exception of Daryl Weaver, who is Vice President of Networks for Blue Cross Blue Shield of Alabama. He and his colleague Ann Schmidt have graciously joined us, and it'll be a great advantage to us to have the perspective of an insider in the insurance industry as we talk about all the issues that we've talked about in the last couple of weeks. Now, the way we're going to do this, just to sort of open the discussion, Dr. Cortez and I are going to offer opposing pessimistic and optimistic perspectives on the ACA and its results. And we usually alternate. I mean, it's, of course, the last word is always a bit of an advantage, and last year I had the last word, so this year Dr. Cortez is going to have the last word. And I will begin by pointing out some of, I think one of the things that we both would say is that as this has evolved, as the results of the ACA have crystallized more and more in the last several years, it's much more of a mixed picture for both of us. Both of us are going to acknowledge good things that have happened and that will happen. Welcome, Dr. Saggs.
Thank you. I'm late.
And both of us are going to probably acknowledge some bad things that have happened. And the difference is really going to be one of emphasis rather than perhaps the degree of absolute disagreement that might have been there in the past. So the glass is half empty. If I say the glass is half empty, I'm acknowledging that the glass is half full. And it's very clear, but before I tell you what's very clear, let me ask the Dr. Curry question in a slightly different form. It's probably too soon for me to have made you all sit here. I mean, if you want to sit up here while Stefan and I are talking, and then you can come down.
But this is temporary, correct?
Of course.
Not a permanent commitment.
Okay, this is interesting. It's true that this year you all are more favorably disposed to the ACA than classes have been in the past. We saw that from Dr. Curry's slide. And perhaps a preference for a market-based direction compared to single payer is reflective of Alabama in a way that it would not be reflective if we were in Massachusetts. I mean, those lines would be opposite. But that's interesting. I want to begin by acknowledging that the glass is half full. We had a huge problem with access prior to the passage of the ACA. I think we can argue about where the problem really was or where it was probably the worst. I think many would want to argue that non-citizens is a bit of a separate problem. I mean, of course, we want to help non-citizens, but we as a nation have to decide what to do about that, and we really haven't decided what to do. That's going to be a less tractable aspect of the problem of access than some of the other aspects of the problem. Many of those who were uninsured historically have been people who could have been insured had they chosen to be. Massachusetts showed very clearly that people over 300% of the FPL were able to get insurance. Massachusetts achieved 100% coverage with subsidizing those below 300%. People above 300% are able to do it. The people we probably really wanted to help were the bottom two segments of this picture. Those who are older and lower income, that 10.6 million people in the bottom, and then childless adults, often who were not eligible for Medicaid. I mean, those are probably the 15 million or so of the 45 million that especially needed help prior to the institution of the ACA. Now, what's been accomplished? A lot has been accomplished. I mean, we can talk about the different estimates of how many people have achieved coverage. I'm sure Stefan's going to emphasize the HHS number. Most of those numbers come from survey data. The bottom one, I think, personally, I'm going to suggest we should pay attention to because this actually comes from insurance company data. Enrollment data from data sets from insurance companies that actually provide a harder number than simply a Gallup pollster asking people on the phone, do you have insurance or do you not? So however way you cut that, millions of people have coverage now that didn't have it before. And that's great. That's wonderful. We needed to do that. I mean, it's to our shame that we did not do that before now, being a wealthy country. And we could have done it. Now, how has that actually played out on a more granular level? And if we actually look at the proportions of people in the different sort of segments of insurance coverage and what happened to them, what we see that although there's a net 6 million increase in the individual market, that's also been accompanied by a significant shrinkage in the employer-sponsored market and a significant amount of churn in the individual market. I mean, a lot of people lost their policies initially, got other policies perhaps which they were less happy with. A lot of turmoil sort of underlies these numbers. But I think the point to make is that the major effect of the ACA was to expand Medicaid. Most of the increase in insurance coverage, perhaps 85%, I suspect that's probably the accurate number, comes from people having Medicaid who didn't have insurance before. 15% in the individual market, not an insignificant number, but a much smaller number compared to the Medicaid number. That's what the ACA really did. A vast coverage expansion for an existing government program. The point I want to make here is simply that most of that expansion happened in the first 2 years. Fall of 2013 was the first open enrollment period for the individual market. There was a big expansion in the 2014 calendar year, a small one in the 2015 calendar year, and it really stopped increasing rapidly in 2015, and 2016 looks the same. The point is, we're basically where we're going to get, most likely. I mean, in spite of projections that the numbers of those insured are going to continue to go up, there is deep reason for skepticism that that's actually going to happen as things stand today. Now, one of the probably points of major disagreement between Dr. Cortez and myself concerns the individual market. I mean, in past talks, when he does this, he begins by saying what a horrible thing the individual market was, and how nice it is that we have now turned it into something very different than it used to be. And I'm going to make the argument that, in fact, it's exactly the other way around. The individual market, if one looks at it from the standpoint of what it could have been expected to do, actually functioned very well. It functioned very well for those who could afford to participate in it. Of course, many could not. It did have its flaws. Occasionally, insurance companies were bad actors. There were cases of insurance companies doing bad things. But on the whole, it successfully gave people coverage they needed at a price that they were able to afford, and it protected people from expensive, bad outcomes, which is what insurance is supposed to do. In the fall of 2013, roughly 6 million people were told that their insurance coverage was canceled. Not that they couldn't get another policy, but that other policy would likely be more expensive and less attuned to what people wanted than their policy had previously been. And I think the poignancy of that moment was captured in a letter written by a young woman in California to the president of Anthem Blue Cross in the fall of 2013, when she said, "I was all for Obamacare until I realized that I would be paying for it. I was the one who was going to be paying for it." When she was told by Anthem Blue Cross that her Blue Cross premium was going to double. And that was a kind of emblematic instance of what happened to millions of people in the fall of 2013. Now, insurance companies didn't really know what they were doing at that point. They didn't know what the new pool was going to look like. They anticipated that young and healthy people were going to sign up, and so that the high-risk people that signed up would be balanced out. So they set their premiums accordingly, and they lost their shirts. They basically lost their shirts. And premiums in 2015 jumped enormously. In 2016, the results of what happened in 2015 are now beginning to sort of become clear. And in general, they lost their shirts again. We can interrogate Dr. Weaver about this, about how Blue Cross of Alabama did in 2016. And I must admit, last year I sort of looked at the numbers. This year I haven't done so. We'll see if he confirms or disconfirms what I'm telling you. The premium set rates for 2018 are not yet out. They will be in the next month or two. My prediction is they are going to jump up in a big way once again. And Daryl perhaps will also be able to shed light on whether that's true here in Alabama. Now, we talked in the first couple of sessions of what happens when premiums continue to accelerate upward. Young and healthy people, it becomes a worse and a worse deal for them. A death spiral is a possibility. That may not happen. I mean, it may be that the market's going to stabilize. Some are predicting now that it is stabilizing. But if it does stabilize, what that's going to mean is that the individual exchanges will basically be a kind of substitute high-risk pool. The people that are buying those policies are people that are heavily subsidized, so that the cost of those policies doesn't really affect them. The large proportion of eligible people who are not subsidized are not buying those policies and probably are not going to buy those policies. Why are they not going to buy those policies? Because if you're a family and you're not subsidized, you're going to be facing a premium in the $1,000 to $1,500 per month range for a policy that has deductibles in the $6,000 or $7,000 a year range. And unless members of your family are sick, you're not going to really be able to make much use of that, and it's not really going to be an attractive proposition for you. So the present situation of most eligible, healthy people who could get into the individual market choosing not to do so is probably going to continue. Now, what about the other effects of the ACA? Many have predicted that it would lower the prevalence of employer-sponsored health insurance for various reasons. If that's beginning to happen, it's only slowly beginning to happen. I mean, I did show you that there were several million fewer employer-sponsored health insurance people recently compared to before. We can argue about that. I mean, clearly, employer-sponsored health insurance was diminishing before the ACA, which I would fully acknowledge. But I think we have a powerful mechanism here as to why the ACA probably is making a contribution to that trend. What about the ACA and the broader economy? I mean, what's it doing to our capacity to continue to pay for the healthcare expenditures, which the ACA has not really done anything about the rate of increase in? And this is another area of controversy. Those who look at employment trends and the fact that employment has actually risen rather nicely in the last year or two are going to make the argument that the ACA has really not had any negative effect. But scholars who have actually surveyed small businesses about their decision making tell a different story. In fact, the ACA is costing the economy jobs and is progressively diminishing the ability of we as an economic engine to pay for the healthcare colossus, which is in no way been diminished by the ACA. What needed to happen, in my view, was a complete change on the supplier side of the market. The insurance model of fee-for-service, no control of physician practice, rewards for volume, all of the things which I've made the case have had a deleterious effect on healthcare spending over the course of many, many years, have not in any way been altered by the ACA. This is what needed to be blown up. It was not blown up. So we have done good things with coverage. I mean, we did it by expanding a very dysfunctional government program, which we have not reformed. We could have done a lot better there, but I will agree with Dr. Cortez that it is a good thing we did that, barring the absence of anything better. He will show his picture of the ship and all this. Oh, you're not going to show the picture? Oh, the ship's gone? Okay. I won't talk about the ship. So we've helped a lot of people who needed help. In doing so, we have needlessly harmed many in the individual market. We have begun to harm and are going to increasingly harm the economy while perpetuating aspects of our current system that are threatening our national future. So yes, the glass is half full, but the glass is also half empty. And my argument would be we need to bring back the individual market. We need to make it more of a market than it was. We need to enable people who couldn't participate in it to do so. We need to reform Medicaid and Medicare. We need to break the bond of insurance with work. We need to subsidize those who need help into buying it. We need to let it be real insurance. Let insurance companies do what they're able to do, judge risk and price it accordingly. And we need to nudge our safety net programs toward competitive health insurance markets. Why do we need to do all that? I mean, alternatively, we could go to single payer. Single payer would solve all of these problems in a different way. It would solve the cost problem by simply limiting what we as physicians can do. It's an option. What I don't like about it is the fact that it takes away everybody's choice and makes decisions on all of our behalf at a level way above us, and which may be decisions that we're not going to like. Now, I don't want to suggest that the particular brand of poisonous, punitive moralism, which informed this decision made in England about a year ago to deprive people with behavioral problems of medical care that they need, would necessarily be made by whatever expert panel determine what is going to be covered in a single-payer system here in the United States. Hopefully it wouldn't. But could it happen? Could that happen? I don't think even Dr. Cortez would suggest that it couldn't happen. I would rather all of us have a system in which we can make choices, in which there are exit options, in which if we don't like the insurance company we're with, we can go to another one. And if we don't like the doctor we're with, or the healthcare system that we're with, we can go to another one, rather than have all important medical decisions made by a committee which is likely to be democratically unaccountable. Dr. Cortez will tell you that healthcare is too important to be left to the market. I will tell you that it's too important not to be left to the market. We need to be able to make choices, which we will not be able to make if Dr. Cortez's preferred direction is the direction in which we go. Thank you.